If you see the Western data, Western 2 and the Asian data, like considering the old gold standard trial like ACTS GC trial, that is 5 years 61% 71, whereas with coming to the if you are adding CAPOX, that is capecitabine and oxaliplatin, the 5 years survivals improved from 69 to 78. Whereas if you the latest standard of care that is perioperative chemotherapy, Western 2 data, that is FLOT, is a standard of care wherein which we are thinking of 5 years survivals of 45. Asian, the postoperative adjuvant chemotherapy is a standard of choice. Majority of the times, more efforts are required for the better regimen with or without RT. With the ISOPEC, even in the neoadjuvant space, the RT's role have come down. With the more so, even in the adjuvant thing, RT is eliminated for majority of the times. The only space where we consider adjuvant RT is either a suboptimal resection, like as we previous speaker said, D2 is the optimal resection. Suppose if you have got a D1 or less than D2 resection, or if it's a positive margin, these are only two indications where the RT is required. Now with the advent of ISOPEC and the other trials, the RT's role in the stomach is almost gone. FLOT has now become the standard of care. This have been already covered. This is a repetition of a slide, classic versus FLOT trial comparison, adjuvant versus periop. If you see the comparison of first generation phase 3 trials which have been seen like INT 0016 MAGIC and CALGB, esophageal tumor, esophageal gastric junction tumors are 20% and majority stomach are around 80%. And in this, if you have performing D2 resection, FLOT 4 AIO is the regimen to go ahead. There have been efforts in improving the outcome for these operable gastric cancers. One is by treatment de-escalation so as to improve the tolerability. Next is treatment intensification. Neoadjuvant has been already covered. And the fourth one is adding adjuvant IO. So first one is JCOG 1104 trial. S1 for 1 year should remain the standard of care even for the adjuvant chemotherapy of stage 2 gastric cancer. Like in the de-escalation thing, CAPOX versus only S1. If you wanted to give S1, the duration should be 12 months. Whereas if you wanted to give CAPOX, the duration is 8 cycles or 6 months. Next, treatment intensification. Is there any role? Adding RT. As I clearly said, there is no adding adjuvant RT, especially except for if it is a less than D2 resection, there is no role of treatment intensification with respect to RT. Treatment intensification, is there any role? No. Even in if you are adding RT to S1 alone, there might be little benefit, but if you are adding S1 plus capecitabine and RT, there is no role. Neoadjuvant therapy has been already covered. Now the same thing, if you have got perioperative chemo or upfront gastrectomy, the patient who has got underwent less than D12 dissection only, there is a role for chemo radiation. Otherwise, there is no role. This has been already covered, like when to do MSI high or DMR testing, and is there any role of prior to Taxanera and post Taxanera, what is the benefit? Last slide, the previous speaker has said, like post chemotherapy in surgical setting by addition of immunotherapy is what is the benefit? Yeah, durvalumab, definitely we could see increase in PAT-CR rates from 7 to 19. The FLOT, which has been standard of care, has achieved the PAT-CR rates of around 7 to 10, whereas if you add durvalumab, it is 19. If you have got pembrolizumab plus FLOT, it is 17. If you have got atezolizumab along with the adjuvant, it is 24%. And if you have got only FLOT, it is 16%. Thank you for your patient hearing.